Hello and welcome. Today, we'll be discussing a rare but devastating complication of pregnancy and childbirth: amniotic fluid embolism, or AFE. It's a condition that can strike suddenly and unexpectedly, leaving both mother and baby in grave danger. We'll explore what it is, why it happens, and what can be done. The exact cause of amniotic fluid embolism is still not fully understood, but it's believed to occur when amniotic fluid, fetal cells, hair, or other debris enter the mother's bloodstream. This usually happens during labor and delivery, or sometimes shortly after. While the presence of amniotic fluid in the maternal circulation is relatively common, it doesn't always trigger AFE. The reaction that follows, rather than the mere presence of the fluid, is thought to be the primary driver of the syndrome. Risk factors are debated, but factors like advanced maternal age, multiple pregnancies, induced labor, cesarean section, placenta previa, and eclampsia may increase the likelihood, though AFE can occur even without any identifiable risk factors. The pathophysiology of AFE is complex and involves a two-phase response. In the initial phase, the entry of amniotic fluid triggers a sudden and severe reaction in the mother's body. This leads to pulmonary hypertension, where the blood pressure in the lungs rises dramatically, putting a strain on the heart. Right ventricular failure can occur. This is followed by an inflammatory response, activating the complement cascade and releasing mediators like histamine, leukotrienes, and cytokines. These substances cause widespread vasodilation, leading to hypotension, and also damage the lining of the lungs capillaries, leading to pulmonary edema. The second phase involves disseminated intravascular coagulation, or DIC, a condition where the blood clots excessively throughout the body, followed by depletion of clotting factors, leading to severe bleeding. Amniotic fluid embolism is a rare event. Estimates vary, but it's thought to occur in approximately 1 in 40,000 to 1 in 80,000 pregnancies. However, because it is often underdiagnosed, the true incidence might be higher. It's important to remember that while rare, its severity makes it a significant concern for obstetricians and maternal, fetal medicine specialists. It has been observed to happen more in mothers with advanced age and multiparity. The signs and symptoms of AFE can be abrupt and dramatic. The initial presentation often involves sudden shortness of breath and chest pain, followed by acute respiratory distress. Hypotension and cardiovascular collapse quickly follow. Many women experience seizures, and some may lose consciousness. Massive hemorrhage, often from the uterus or at the site of cesarean section, is a common complication due to the development of DIC. Fetal distress, indicated by changes in the fetal heart rate, is also frequently observed if the baby hasn't already been delivered. Diagnosing amniotic fluid embolism is challenging because there are no specific, definitive tests. The diagnosis is primarily clinical, based on the sudden onset of characteristic symptoms during or shortly after labor and delivery. Supportive tests may include blood gas analysis to assess oxygen levels and acid-base balance, coagulation studies to evaluate for DFE, and chest or CT scans to look for pulmonary edema or other lung abnormalities. The presence of fetal squamous cells or other fetal debris in maternal blood samples was once considered diagnostic but is no longer considered reliable. Currently, clinical criteria, supported by exclusion of other possible causes, remain the cornerstone of diagnosis. While there aren't distinct types of AFE, the severity can vary significantly. Some cases may present with milder symptoms that respond to supportive care, while others can rapidly progress to cardiovascular collapse and death. The speed and intensity of the immune and coagulation cascades determine the clinical outcome. Treatment for amniotic fluid embolism is primarily supportive, aimed at stabilizing the mother and addressing the immediate life-threatening complications. This includes providing oxygen and ventilatory support, often requiring intubation and mechanical ventilation. Intravenous fluids and vasopressors are administered to maintain blood pressure. Blood transfusions and clotting factors are given to manage DIC and control bleeding. Cardiopulmonary resuscitation, or CPR, may be necessary. Prompt delivery of the baby is crucial, if possible, to reduce the burden on the mother's cardiovascular system. Extracorporeal membrane oxygenation, ECMO, is a treatment option that has been used with success in AFE. A multidisciplinary approach involving obstetricians, anesthesiologists, critical care specialists, and hematologists is essential for optimal management. Currently, there are no specific preventative measures for amniotic fluid embolism, given the unpredictable nature of the condition. Careful monitoring of the mother and fetus during labor and delivery is crucial, along with prompt recognition and treatment of any potential complications. The early identification and management of risk factors like preeclampsia and placenta previa may potentially reduce the risk. The prognosis for amniotic fluid embolism is guarded. Historically, it was associated with very high maternal mortality rates, but advances in critical care have improved outcomes somewhat. However, it remains a leading cause of maternal death. Survivors may experience long-term complications, including neurological damage, respiratory problems, and psychological trauma. The prognosis for the baby depends on the gestational age at delivery and the extent of fetal distress. Ongoing research focuses on identifying biomarkers that could help with early diagnosis and developing targeted therapies to modulate the immune and coagulation cascades that drive the disease. Further studies are also needed to better understand the underlying causes and risk factors for this devastating condition.